Top Med Talk.
Hello, welcome to Top Med Talk. I'm Andy Cumpstey here at the American Society of Anesthesiologists annual meeting, Anesthesiology 2025, in the beautiful San Antonio, and I'm joined by my wonderful co-host, Kate Leslie.
Hi Andy, how are you going?
It's brilliant to be here, isn't it? Really fantastic meeting. First day today, and the exhibition hall is slowly filling up around us.
It is. I've never been to San Antonio before. In fact, I've never been to Texas.
Me neither.
It's quite the experience. It's very hot.
But actually a very welcoming place. It's been quite pleasant walking down alongside the River Walk yesterday, seeing around, not what I expected Texas to be like, but actually lots of green places, rivers, cafes, bars. There's a real good buzz about the venue. And we're delighted here to open our sessions at Top Med Talk with two fantastic guests. So thank you both for joining us. It's a real pleasure to welcome Stacie Deiner and Mark Neuman to the podcast.
Thank you.
Thank you, Andy.
Stacie, if I come to you first, could you tell our listeners a little bit about yourself, where you work and what your background is?
Yes. So I've worked most of my career in New York City at Mount Sinai, and about 5 years ago, I took a wonderful job at Dartmouth Health in New Hampshire. Dartmouth Health is the most rural academic center in the United States. Oh, wow. Fun fact. So from the big city to the country.
Fantastic.
Mm-hmm.
And Mark, same question to yourself.
I'm Mark Neuman. I'm a professor of anesthesiology. I work at the University of Pennsylvania in Philadelphia.
Well, thank you both for joining us here today. First day of big meeting, our first opening session here in Top Med Talk. I'm really keen to hear about what you're both presenting at the meeting. And I believe you've both got a session later talking about a new guideline.
Thank you, Andy. I am so excited to talk to the membership and all the visitors and guests about the ASA guidelines for older adults. This has been years in the making, and we were just so excited. Mark and I don't know if you remember this, Mark, we did a survey about people doing care for older adults and screening. And when we asked people what they most wanted, anesthesiologists, what they most wanted is that they wanted the ASA to come out with guidelines to help them start to take better care of older adults. I'm going to show that slide from that paper later.
Yeah, I mean, this is something we've been working on since 2017, when we were both on the ASA Committee on Geriatric Anesthesia, and we proposed this guideline back then. Stacie, you and I worked on that survey together as a partnership between Brain Health Initiative, which the ASA had done, and the Committee on Geriatric Anesthesia. Showed that need. It also showed that there were huge gaps in care, real variability in care, and using things like expanded preoperative evaluation, frailty screening, the counseling about risks. This guideline, which came out as the first ever guideline that the ASA has ever done, focused on the care of the older adult, was really an important moment. And it was led by Frederick Sieber at Hopkins, and Karen Domino. They did a fabulous job with it, and they came up with a number of useful recommendations that I think anesthesiologists in the U.S. will appreciate using, and it'll also be relevant for folks in other places.
And so how did the ASA committee that you were on, how did that process work? Who did you co-opt to help, and how did you come up with the recommendations, Stacie?
No, not me. This was a giant effort from many, many people. Actually, there's a whole process around the ASA deciding to even do a guideline or best practice document. So we had to queue up, because they can only do so many at a time, because they put giant resources behind putting this together. There's a librarian team and methodologists. This is an exhaustive review, and it was wonderful to work with all of my colleagues to synthesize the literature and come up with some guidance for our membership.
Why don't we cut to the chase and find out what the top recommendations were?
I had the pleasure of working on recommendation number 1, which had to do with expanded preoperative evaluation for older adults. The question really was, does expanded preoperative evaluation improve outcomes for older adults? And so we looked at a wide number of outcomes. We looked at delirium, neurocognitive function. We looked at discharge to a nursing home. We looked at 30-day mortality. We looked at functional recovery. Expanded preoperative evaluation was a little hard to wrap our heads around, because everybody did sort of a different combination of things. And in many cases, it was bundled care. But what we were able to see is that the synthesis pretty consistently showed a reduction in delirium for patients who had a bundle of preoperative evaluation.
That's fantastic.
Yeah, it's pretty exciting.
And what was recommendation 2?
Recommendation 2 was around choice of anesthesia technique for older adults. It's something that
Your area.
that I've been thinking about for a long time, and I've done research on, and we published a trial called the REGAIN trial on this topic specifically. And what it was really looking at whether using neuraxial anesthesia versus general anesthesia for any range of surgical procedures in older adults could change outcomes. It was a strong recommendation that either option would be reasonable in patients who lacked contraindications to one or the other, mostly focused around the issue of delirium. That was where the strongest evidence was across multiple studies. Choosing spinal or epidural anesthesia for your hip fracture, for your elective joint, for your lower extremity revascularization wasn't likely to alter your risk of delirium after. And the recommendation was to use shared decision-making to help patients choose what was the best option for them.
You know, the REGAIN study is one of my favorite studies.
Thank you for saying.
All time.
Thank you.
It was so hard, you know, and you screened tens of thousands of older people, and it was multi-center, and you know, it really was a spectacular effort, I must say.
Well, thank you. It means a huge amount coming from you, but I really do appreciate it.
It was one of those trials that everyone said needed to be done and was so hard to do, Andy.
Absolutely. And you've given us the headline results straight there, but I think there's a lot more interesting detail in some of the layers lower down, isn't there? Some of the secondary outcomes, which I found a bit surprising. You want to talk about some of those?
Thank you, Andy. We studied the REGAIN trial, a study of 46 hospitals in the U.S. between 2016 and 2020, and we randomized 1,600 patients to spinal anesthesia versus general anesthesia for hip fractures. Our main outcome was whether people could walk independently again after fracture at 60 days based on input from patients. People told us that's what they cared about, and we found no difference between techniques. We looked at delirium and found no difference there. We looked at length of stay. We also looked at patient satisfaction, and you know, the good news was the patient satisfaction was high with both techniques, but it wasn't particularly different. We looked at things like pain and opioid use. We found no real difference there. We did find some very, very subtle differences, but they were going against what our hypothesis was, which was that spinal would be better. There were a number of things. There's a trial finishing up in Europe now. We're excited to see those results soon, and maybe there'll be opportunities for us to bring the data together. As with these trials, when you finish a trial like this, it's always wonderful to learn from it, but you realize how much more there is to do. And so even going through all that, you feel like, oh, it's still not enough. And so my real hope is that there are other studies that come out to go deeper and deeper. Because as you say, Andy, there's a lot of other layers to study, subgroups of patients who might be more at risk. And those are the questions that people have brought to us since we published the results.
So maybe if we've got time, we can pivot back to that a little bit. It's great that trial is already fed directly into this guideline. What are the other recommendations in this guideline that we should talk about?
So there were two other big recommendations and one sort of suggestion. The other recommendation, Stacie talked about multidisciplinary preoperative evaluation. There was neuraxial versus general. There were recommendations around use of dexmedetomidine. There was a conditional recommendation that use of dexmedetomidine could be reasonable to prevent delirium, and that total intravenous anesthesia or general anesthesia would both be reasonable options. There was also a best practice statement about avoiding medicines in older adults that might be potentially inappropriate. So there were 4 recommendations and then a best practice statement. One meta observation, though, applies to REGAIN. There was a lot of good randomized evidence to go into this, but there's always a need for more. Many of these recommendations had low or moderate quality of evidence, so they all need to be taken with a grain of salt. My hope is that early stage investigators and researchers can look in the guideline and say, okay, there's gaps to be filled in.
Well, and I think the landscape of how people do trials has really changed, right? From when you and I met at this point, probably close to 15 years ago, people were focused on anesthetic neurotoxicity and smaller studies. Now I think people really have these big trials networks. I think we're able to, electronic health records are ubiquitous, and this really allows us to collect data and do big definitive studies in a way that we just didn't do a decade ago.
I've got a provocative question to follow that up. In this era of big network trials, big data, AI, when we talk about work still to do in subgroups, individualizing our care, how do we square those two challenges?
I think you have to collect the data before you start to narrow it down. It's wonderful to be able to do a pragmatic trial that looks like how people practice and is not so narrow that you're excluding 3/4 of the people who might benefit from what you're proposing to do. I think you collect the big data and then you do the sub-analysis if you can.
Yeah, I agree, Stacie. I mean, it's a great question, Andy. And we hear a lot when we talk about things like AI, about this future where we have a challenge separating the real from the fake, right? That you'll see a video online and say, oh, that looks like, my relative, but that's actually something that's just been synthesized. I mean, this is a real fear. I think in science, we're going to face a very similar threat, not necessarily in terms of fabricated data, but in terms of an explosion of results. And we're already in the midst of it, which are confounded and hard to make sense of. I think doing trials is very special. And this is stuff that I've learned from people that inspired me. You have the opportunity to randomize people to assignments, and that gives you insights about cause and effect that you can't get any other way. There are retrospective studies we can do, and retrospective studies are inexpensive, and there are many of them out there, but many of them are very confounded, and it's hard to make real good sense. One thing that I think is a real challenge is when I talk to practicing clinicians, it's really hard for them to sort the signal from the noise. When you see 10, 20, 30 papers on a topic like regional versus general anesthesia coming out that are retrospective, and then one randomized trial in there, how do you know that that's the one to pay attention to? Guidelines are important for sorting that out, but even still, there's a flood of information, and I think that's just going to accelerate. So it's a challenge for educating the field, a challenge for how we message these things. I think it's a real risk.
What you're talking about makes me think about implementation of change. One thing we haven't talked about yet is that Mark's currently got a study going on called, my hospital's part of it, called My Anesthesia Choice, that actually uses shared decision making in patients with hip fracture to help practitioners implement the idea that there's real equipoise about which anesthetic technique is better for older adults, and that you can talk to patients about that equipoise. And it's been such a fun study to do, but it also highlights the fact that very rarely do we have studies that do the next thing, which is implementing these results in trials and looking at effectiveness.
I was wanting to talk about implementation as well, because organizations create guidelines. They're for the clinicians to, actually inform them about what to do. But I think more importantly, they're tools for clinicians to use when they go to government or hospital systems with requests for more resources. The things that you have suggested that we implement include some very expensive strategies, specifically multidisciplinary preoperative clinics. So what has the ASA and the committee got in mind for the implementation of this guideline, and what are their intentions for how ASA members and others should use it?
Well, so it's multi-pronged. Part of the reason I'm here in San Antonio is to rep these guidelines, but there's also been podcasts that have come out through the ASA. We've also worked with Johnny Hartford Foundation. We got a grant to make tools for screening and education about screening older adults free, not just to ASA members, but to anybody who logs on to the ASA website. It's interesting that you start to talk about government and getting resources. Coming up in 2026, Medicaid and Medicare, CMSS is going to start to roll out a difference in how people are paid in the United States for care bundles in 5 major different types of procedures. Mark, I see you nodding. Has your hospital started to talk about CMSS teams?
I think at high level, yes.
Yeah, so just for our international listeners, Medicaid is for low-income people and Medicare is for older Americans.
That's right. And so people who receive insurance through these payers, if their episode of care, which includes a pre-op period but goes all the way out to 30 days, exceeds benchmarks for their region, the hospital is going to start to lose money. This has gotten a lot of people in the United States excited about thinking about how to proactively screen their older adults to understand how to reduce risk and improve their care.
And I guess that screening process comes back to some of the recommendations you mentioned in the guideline, but you talked about reducing unnecessary medications in these groups. I just want to pick up on that a little bit. What sort of medication categories should clinicians be thinking about, should they be looking at, and how do we implement that into this process going forwards? Because that's such a wide-ranging topic, right?
Right. I mean, I think that was a best practice statement, so it wasn't at the same level of the recommendations. Reducing potentially inappropriate medications in older adults is something that geriatrics as a community has been emphasizing for a long time. Stacie, you were part of a guideline years ago through the American Geriatric Society to apply their BEERS medications, which are the medication list that they have that's potentially inappropriate for older adults, to the perioperative setting. I think what's important is understanding that list, which includes things like benzodiazepines, opioids, stuff that we use commonly in the periop space, may or may not fit exactly. But I think there's a general principle which I teach and try to adhere to, which is less is usually more. If something doesn't have a likelihood of benefit, incurring additional risk of polypharmacy is often not worth it, especially in an older adult where there may be other things going on.
I'll add one more category for the listeners. Anticholinergic medication, which is part of a post-op nausea vomiting bundle, was used fairly ubiquitously in the United States. Scopolamine patches, or even IV or IM diphenhydramine, metoclopramide, all kinds of drugs like that were used in older adults with the thought that it should reduce postoperative nausea vomiting, but really they're not a super high risk category for postoperative nausea vomiting, and they're much higher risk for having postoperative delirium.
Which presumably is increased by the use of those medications.
Yes.
Interesting.
So what else are you looking forward to? Anesthesiology 2025.
This is always an inspiring meeting for me. I love going around and, of course, seeing friends, seeing what's new. But I usually leave here with new ideas and things I want to do in research, questions to ask. I'm excited to go into it with an open experience. I'm getting a chance to be on a panel on Monday that will focus on large-scale PCORI-funded trials. PCORI was the U.S. funding organization that funded our REGAIN trial. I'm excited to see what else is going on. I'm getting to moderate a panel for the journal, both one today and one on Monday. Today's panel is going to be late-breaking trials, so really excited about that. And the one on Monday is about frailty. I'll get to hear more from Stacie about how she's applying frailty in practice and what current evidence is.
Do you want to give us a few highlights from your talk about frailty?
Sure. I think in the anesthesia community, it is underappreciated that there's a big overlap between patients who are frail and patients who go on to develop delirium. It's been long known that people with preoperative cognitive impairment, that's like the big risk factor for having postoperative delirium and cognitive decline. However, physical frailty incurs about twice the risk for postoperative cognitive dysfunction. There's some evidence from postmortem studies that if you match brain pathology against whether someone was considered demented at the time, patients who are frail are more likely to express their neuropathologic burden. Someone could have the same thing going on in their brain, but if they're physically frail, they're more likely to manifest the symptoms.
That's fascinating. So how do we respond to that observation? What do we differently as clinicians? What should we change in our practice?
Well, I think everybody's starting to get excited about the idea of prehabilitation, of optimizing nutrition. I think they're starting to think about biomarkers that may identify people who are high risk even when they look fairly normal at the outside. And, we were talking about things that we're excited about this meeting. I'm doing a small pilot about nutrition, and I'm going to meet up with some friends who are also doing nutrition work. We're both looking at the future. We found these associations, but we're thinking about implementation and better care for older adults.
One of the fascinating things about frailty is the intersection with frailty and obesity. Particularly in countries where we imagine traditionally the frail person to be a little old stick, lady. You can be frail inside what looks like a big body, can't you?
That's completely underappreciated, although I think on social media, people talk about metabolism and metabolic syndromes and optimizing your metabolism all the time. But we really haven't capitalized on that yet for how we take care of people in the perioperative period. I think we're starting to head into a time of perioperative medicine, not just thinking about what medicines we give in the operating room, but optimizing people's health.
Well, I think that's a really positive note to draw to a close on. But looking ahead, what are the key things on the horizon that we should be doing to optimize people's health in the perioperative space, particularly with the older adult?
Well, I think that to the American Society of Retired People is very active in the United States about putting proactive messaging for older adults about what they can do around the time of surgery. There's a wonderful sheet that recommends people that they should start walking, they should decrease their alcohol intakes, quit smoking if they can, ask good questions, and ask for support from their family and the people around them. Mobilizing the public to take care of their health and be partners in their recovery is the next phase.
Fantastic. Same question to you, Mark.
Yeah, I couldn't agree more. Stacie mentioned some of our research on shared decision-making. And leading up to that, we spoke to a lot of older adults about their experiences, having conversations with anesthesiologists or decisions about anesthesia. We learned that there's a real desire on the part of patients to be involved in their own choices. Having surgery for older adults can be a moment where there's a real loss of control or feeling of vulnerability. Engaging people in decisions about their own care is a way of giving back some control, some agency. And in this research that we're doing through My Anesthesia Choice, which is our effort to implement the regained findings into practice through shared decision-making, it's been wonderful to see patients and clinicians engaging. And what we've learned is that through very simple things, just showing that there's a choice and offering information, you can engage folks as partners in their own care. So I think that that's one thing that I hope is on the horizon for our field as a future, to really bring back some of the physicianship and humanity into these conversations, to really give folks an ability to be part of their own care. So that's something I hope for the future and that I hope we'll research more and do more.
Couldn't agree more. It seems to come to this point in these conversations, we talk about the power of the conversation. I think that's the really enduring thing to be looking forward to as we go forward. So thank you, Mark. Thank you, Stacie, for joining us here on Top Med Talk.
Thank you.
As always, you can find this podcast on our websites, on your podcaster of choice, whether that's Apple, Spotify, whichever one it is. We're on social media. If you do find us on social media, please do hit like, please do hit subscribe. It makes a massive difference to us. Of course, it's important to thank our sponsors, without whom we couldn't keep Top Med Talk open access and free at the point of listening around the world. Thank you to the ASA here for hosting us here in San Antonio. Thank you all for listening.
Cheers.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EdPom, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is edpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. edpom.org.